Hey y'all, it's Simply Surgery. I'm Nico and I'm here with Spencer. Today we'll be discussing central venous port placement.
Thank you, Nico. So first thing we want to dive into is what is the overall goal of this surgery?
The overall goal for this operation is to place a port for central venous access and to keep it stable and in place under the skin. And the reason that we do this is for long-term administration of medications or fluids. When you have a line coming out of you, it's inconvenient for a patient and it has a major infection risk. And so having a port is to help avoid infection and to really just be there for patient convenience as well.
And so what are the reasons, and in other words, what are the indications for needing this surgery in particular?
So the indication for the placement of a port is the need for long-term central venous access. This would be for things like administration of chemotherapy or other substances that can cause damage to peripheral veins, to the tissues if given peripherally. You can also include the need for long-term administration of hyperosmotic substances, and it can also include TPN. So if you need long-term total parenteral nutrition, such as in short gut syndrome, a port may be a way to get you that without having an increased risk of infection and needle sticks.
Let's go ahead and move forward to contraindications. Can you tell me a little bit about the absolute and the relative contraindications for this operation?
So the absolute contraindications for this procedure would be that the patient just isn't a candidate for surgery at all. They currently have a vascular injury, an active soft tissue or skin infection, that they have a severe uncorrectable coagulopathy, or that they have current sepsis or bacteremia. Relative contraindications are things that really need to be outweighed by the benefit of port placement, would be things such as thrombocytopenia, coagulopathy, trauma, a chest wall neoplasm, or the patient has cystic fibrosis requiring chest physiotherapy.
And so what would distinguish coagulopathy from being an absolute versus a relative contraindication?
That's the severity and the incorrectability. If it's not that bad or you can correct it for a time or permanently, then you want to correct it first. But if it's severe and not correctable, then that's something where you just don't want to operate. You don't want to cause this person bleeding.
Great. So what are some things you need to consider before you go into the operating room?
A couple of things to consider before taking a patient back for port placement would be that this can be done outpatient. It doesn't necessarily have to be done under general anesthesia either. You also want to consider the placement side, so right versus left, based on the patient's disease process. Make sure that you're putting it away from any kind of cancer that's growing near the port placement site.
When deciding between a subclavian and an internal jugular approach, the choice is based off of multiple factors such as surgeon preference, patient anatomy, and the placement of prior lines.
Is there really a preference for the side that the port is put in on? I would assume maybe the left, so it's closer to the heart, or are there other considerations that go in aside from tumor location or other disease progression?
So funny enough, it actually takes less catheter to insert it into the right side of the body than into the left side of the body. This is because the venous system drains into the right atrium, which is on the right side of the heart. That means that all of the right-sided veins just take a couple of less centimeters worth of catheter to drain into that right atrium.
Well, interesting. I definitely would not have expected that. Let's go ahead and move into the anatomy. I think we're already on the subject, but let's talk about the external landmarks and what to look for in terms of avoiding anything that you shouldn't be messing with.
The external landmarks that you'll need to look out for the subclavian approach are the sternal notch, clavicles, and deltopectoral groove.
The chest wall is made up of muscles such as the pectoralis major, the pectoralis minor, and the intercostal muscles.
The anatomical landmarks to consider when performing an internal jugular approach include the sternal and clavicular heads of the sternocleidomastoid muscle, the clavicle, and the triangle formed by the three structures.
For this case, you'll also need to know your venous and your arterial anatomy. The subclavian veins drain from the arm, come along the clavicle, and then when they meet with the internal jugular, they form the brachiocephalic vein. The brachiocephalic veins, right and left, meet and form the superior vena cava, which drains into the right atrium. The major arteries you need to look out for when working with the subclavian veins are the subclavian arteries. Other arteries in the area that you need to know where they are but not necessarily look out for in the same way are the carotids and the aorta itself.
So what's the med student going to be doing during the port placement?
Okay, so your number one responsibility as a med student for any case that you're going to scrub is to know your patient inside and out. Some other things you might be asked to do during the case will be things like retraction, so ensuring that the surgeon has adequate exposure to do what they need to do, suturing one or both layers of the incision, and then finally, like with any case, you're going to have to assist with patient transfers and with patient positioning before and after the case.
So now let's actually step into the procedural elements of the port placement.
First of all, the positioning of the patient, you generally want to put them in the Trendelenburg position.
Okay, so we've got the positioning down. What's the first step to the surgery?
So there's two major parts to this operation, and the order of them doesn't necessarily matter.
Those parts are the cannulation of the vein and the placement of the port itself. We're going to start with the cannulation of the vein first. The first step is to mark the site for percutaneous cannulation of the vein.
You're going to want to find the sternal notch and the acromioclavicular joint, and then measure 1/3 of the way from the notch to that joint along the clavicle. It's going to be right around the bend in the clavicle. Measure 1 centimeter lateral to that and mark it. Once it's marked, inject local anesthetic to create a wheal, and then inject local anesthetic in the subcutaneous layer and around the clavicle as well. To create your venous access, advance a needle along, then underneath the clavicle along the track of injection of local anesthetic. This can also be done under ultrasound guidance. Other ways to confirm placement without ultrasound guidance would be looking at the color of the blood and looking to see if the bleeding is pulsatile or continuous and oozy.
And so for the color of the blood, are you talking about different shades of red, or what exactly are we looking at?
Well, it's definitely not like in the illustrations where arterial blood is red and venous blood is blue, but there's definitely a different shade of red that's darker in venous blood than arterial blood. Because arterial blood is also under much higher pressure, it tends to squirt out, and it also tends to be pulsatile because the arteries are pulsing with the heartbeat. Once the needle's in place, carefully run the guide wire through the needle and into the vein. Run the guide wire far into the vein, trying to reach the right atrium. While advancing, you should meet no resistance, and once you're far enough in, step back and confirm correct placement using fluoroscopy. On fluoroscopy, you're going to see that the guide wire does not cross midline if you're coming in on the right side, and that it's going to end in the right lateral border of the heart. Once you confirm accurate placement of the guide wire, secure it if you're not handling it to ensure that it does not embolize. Now that the guide wire is in place, it's time to create the pocket where the port will sit. Make a 2 centimeter incision just inferior to the guide wire site and dissect down to the chest wall, which will be the pectoralis major. Then create a skin flap along the inferior edge of your incision using blunt dissection and electrocautery. The trick here is to make sure that your flap is not too thick, which will cause access issues, and that the flap is not too thin, which can cause necrosis of the overlying skin. Next, use either a tunneling device or other methods to bring the guide wire into the pocket where the port will sit. Grab the dilator and sheath and advance it along the guide wire in its original trajectory into the vein. Once in place, unscrew the dilator and remove it along the guide wire. Advance the catheter through the sheath, and once inserted, you can remove the sheath. Using fluoroscopy again, Confirm proper placement of the catheter.
And then how far are you inserting the catheter in?
So the idea is to have it just at the distal end of the superior vena cava. The rule of thumb is that on the right side, for the internal jugular, it will be 15 centimeters, and for the subclavian, it will be 16 centimeters. On the left side, the internal jugular will be 17 centimeters, and the left subclavian will be 18 centimeters. Next, trim the catheter so that there's not slack remaining, which will allow for kinking. Now it is time to insert the port itself. Put a suture through the chest wall, then through the port. Once the sutures are through the port, remove the needles and secure the sutures in place without tying them. Carefully attach the catheter to the port, leaving as little slack as possible and trimming as necessary. Then test the port and flush it using a mixture of saline and heparin. Now, insert the port and secure it by tying the sutures. Finally, irrigate, confirm hemostasis, and close the skin in 2 layers.
Well, now that we've moved through the procedural steps, let's go ahead and talk about some common complications that might occur from this procedure.
So with any surgery, there's the risk of infection and the risk of bleeding.
With this procedure, you run the risk of accidentally puncturing the artery instead of the vein. You also have a risk of causing either a pneumothorax or a hemothorax, both of which are serious complications.
Later complications of port placement include things like migration, so movement of the port within the pouch or away from the pouch itself, thrombosis, so there can be a blood clot within the catheter,
or in the vein itself. There is also a risk of leak from the port,
which can cause a lot of damage to the surrounding tissues, especially if you're using it for chemotherapy, and device fracture, which can happen after trauma to the port site. A long-term complication of administration of the medications itself, not from the port, would be central venous stenosis. And that's just because the things that we generally put through ports, like chemotherapy, are very toxic and damaging to the veins. And that's why we're going through central veins in the first place.
Finally, the catheter leading from the port to the vein can kink, blocking the ability to administer medication and making the port inoperable.
Well, as someone unfortunate enough to have had a port for a couple of years, I can tell you the migration complication is definitely real. But let's talk recovery time. What does it look like post-op, and what are things to look out for as the patient?
The recovery time from this procedure is generally only a couple of hours, or just however long it takes for the patient to recover from anesthesia. Now, one thing to note about port placement is that the port can be used immediately for administration of chemotherapy or other drugs.
All right, so how can we actually reduce the infection risk during the surgery?
Like with any surgery, we use sterile technique throughout the whole thing. Other things that you can do are irrigating the site before closure, and then making sure that the port does not contact the skin. Even though the skin is prepared and cleaned with an antiseptic before surgery, there's still residual bacteria that can live on the skin, and so keeping the port away from skin contact and making sure that it goes straight from the blue towel into the port site can help reduce infection.
And of course, I think it's important to touch on long-term discomfort issue. Taking a football to the chest does not feel like the best thing with a Port-A-Cath in, but what can you do to avoid those types of pain and misalignments that may come from having one in?
Does that come from personal experience?
I have to say yes on this one.
So a couple of things to make sure that the port does not cause any long-term major discomfort would be making sure that it's in the correct orientation and that it's lying flat along the chest wall. One thing to consider is in women with larger breasts, you want to make sure that there's enough slack so that when she stands up and the tissue is pulled down, the catheter is not pulled up and off of the port.
And then lastly, let's cover a couple of things to avoid. Is there anything else that maybe we've touched on briefly that we should really refocus on here?
So yeah, just to reiterate, to avoid kinking, you want to make sure that you don't have too long of a catheter inside that port pocket. You want just enough to reach the port and nothing else. Finally, to avoid thrombosis, patients need to flush their ports often. This is generally done with a mixture of saline and heparin.
Well, that should wrap it up for today in terms of questions. For this video, we'll actually be releasing a companion video where for once I'll be on the A side of the Q&A, discussing what it's like to have a port actually installed. Thank you to all of our viewers for watching. Go ahead and leave a like, comment, and please subscribe to Simply Surgery. And this is Spencer going out with Nico.